evening, ladies and gentlemen. On behalf of Mumbai Hematology Group and INTAS, it's my proud privilege to welcome all of you here for this interesting webinar on primary CNS lymphoma from A to Z. And we assure you it's going to be innovative and a very interesting talk. Gentlemen on the screen, Professor Dr. M.B. Agarwal needs to be acknowledged for roping in all of us together. He's an institution in himself and teacher of teachers. And as great teachers, they also pass on their baton in important occasions to another able leader in the field of hematology and transplant, Dr. Amit Khurana. We know him very well. He's a fellowship. He had his fellowship in bone marrow transplant, and he is a leading doctor not just in Gujarat but across the country. Highly skilled, extremely approachable, a great mentor, and somebody who is leading hematology under the aegis of Mumbai Hematology Group. Sir, I welcome all of you, and on the same side, I would also like to welcome Dr. Lakshmi Nayak and all our respected discussants today. A warm welcome to all of you. May I request Dr. Amit Khurana to take it forward from here.
Sure. Thank you, Dr. Manoj Kumar, for that kind words. That means a lot to me. Thanks a lot. So very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Lakshmi Nayak from Boston, USA. And she's going to lecture us on primary CNS lymphoma from A to Z. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and the team INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Lakshmi Nayak from Boston, USA. All our discussions were themselves very eminent hematologists as well as medical oncologists, and you participants for sparing your Saturday evening, morning or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 5th of January 2025, from 11:30 a.m. Indian Standard Time and 6 a.m. UK time, your Dr. Paula Walton-Max from University of Manchester, UK, speaking to us on prevention and treatment of infections in the absence of spleen. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Aditya Jandial from Homi Bhabha Cancer Hospital, Mulanpur, Punjab. Dr. Akanksha Garg from Zydus Hospitals, Ahmedabad. Dr. Alok Shetty from Tata Memorial Hospital, Mumbai. Dr. Ashish Dixit from Manipal Hospital, Bengaluru. Colonel Dr. Ashok Meshram from Command Hospital, Kolkata. Dr. Bharat J. Parikh from HOC Vedanta, Ahmedabad. Dr. Bausaheb Bagal from Tata Memorial Center, Mumbai. Dr. Chirag Shah from Apollo Hospital, Ahmedabad. Dr. D.S.K. Sahitya from Medicover Hospital, Vizag. Dr. Deep Gala from SGPJ, Lucknow. Dr. Fahima Hassan from United Institute of Medical Sciences, Prayagraj. Dr. Gopinathan M. from MGM Healthcare, Chennai. Dr. Kripa Bajaj from KIMS Hospital, Hyderabad. Dr. Lalit Mohit Sharma from Mahatma Gandhi University of Medical Sciences, Jaipur. Professor Dr. M. Joseph John from Christian Medical College, Ludhiana. Dr. Narendra Kumar Chaudhary from AIMS, Bhopal. Dr. Nidhi Sharma from SMS Medical College, Jaipur. Dr. Prashant Ganesan from Jipmer, Pondicherry. Dr. R. Prasanna from Kencure Cancer Center, Tamil Nadu. Dr. Rajan Yadav from GCRA, Ahmedabad. Dr. Ramesh Balasubramanian from Velamal Medical College and Hospital, Madurai. Dr. Ravi Kiran Bonanthia from Hassan. Dr. Rizwan Akhtar from SGPJ, Lucknow. Dr. Roshni Bhagwat Pandey from Marble City Hospital, Jabalpur. Dr. Satish Kumar A. from Manipal Hospital, Bengaluru. Dr. Shyam Agrawal from Bhopal. Dr. Siddhesh Kalantri from Blood Care Hematology Clinic, Nashik. Dr. Sudarshan Pandit from Blood Plus Hematology Center, Nashik. Dr. Sumit Mirk from Tata Memorial Center, Mumbai. Dr. Sushil Selvarajan from Christian Medical College, Vellore. Dr. Tushar Pandey from IMS in Some Hospital, Bhubaneswar. Dr. Upendra Sharma from Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Vikas Dalreja from Kanpur. Dr. Yi Mon Ten from North Okalapan General Teaching Hospital, Yangon, Myanmar. Now it's time to introduce our guest speaker for the day. We have with us Dr. Lakshmi Nayak from Boston, USA. Dr. Lakshmi Nayak currently serves as Director of the Center for CNS Lymphoma within the Center for Neuro-Oncology at Dana-Farber Cancer Institute in Boston. She's an Assistant Professor of Neurology at Harvard Medical School. She received her medical degree at Grant Medical College in Mumbai. Further, she completed her residency at New York Presbyterian Hospital and Cornell Campus and fellowship at Memorial Sloan Kettering Cancer Center in New York. Her research interest is in the development of phase 1 and phase 2 clinical trials, utilizing novel therapeutic agents in primary CNS lymphoma and high-grade gliomas, with particular focus on molecular targeted agents and immunotherapeutics. She leads the International Neurologic Assessment in Neuro-Oncology, that is NANO, effort in collaboration with key leaders in neuro-oncology, which led to the development of a standardized scale to evaluate neurologic function in patients with brain tumors. And today she's with us, and she's going to lecture us on primary CNS lymphoma from A to Z. Well, thank you so much. I stop over here. Over to you, Dr. Lakshmi Nayak.
Thank you, Dr. Khurana, for the kind introduction. Thank you to Dr. Agarwal for inviting me, and special thanks to the Mumbai Hematology Group. Of course, as you just heard from Dr. Khurana, I'm from Mumbai, born and raised there, and it's always a pleasure to speak to all of you and others from all over the world. It's a great honor to be invited to speak to all of you, and I will talk about primary CNS lymphoma. I'll share my slides. This disease requires no introduction, despite the fact that it's quite rare. It's a poor prognosis variant of extranodal non-Hodgkin's lymphoma that is restricted to the nervous system. And here we talk about the brain, leptomeninges, or cerebrospinal fluid, eyes, or spinal cord, and specifically in the absence of systemic disease. This is a rare tumor with an incidence rate of 0.4 per 100,000 person year in the United States alone. It accounts for 6% of all malignant primary CNS tumors and 4 to 6% of all extranodal non-Hodgkin's lymphoma. The median age of diagnosis is 65 years of age, and so older patients account for approximately half the cases. And we've noted that the incidence rates are increasing in the age group of greater than 65 since the 2000s. With regard to clinical presentation, most patients present with neurologic symptoms based on the location of the tumor in the nervous system. And the majority of patients have cognitive impairment. That can be quite difficult to determine and differentiate from dementia, particularly in older patients. Walking disorders can also be seen in about 60% of patients. And then hemiparesis, or motor deficits, weakness, and sensory loss can be seen in about 40% of patients. Headache and signs and symptoms of raised intracranial pressure can be seen in about 1/4 of patients. Seizures are uncommon in primary CNS lymphoma for presentation compared to what we see with other brain tumors, such as brain metastases or gliomas. However, we are increasingly seeing seizures in patients that are receiving immune cellular therapies. And I'll talk about those later in the talk. The median performance status at diagnosis is about 60%, but a range can be between 20 to 100%. About 55 to 60% of patients have a single unifocal lesion in the brain. Multifocal or diffuse disease is seen in about 40% of patients. Infratentorial location or location in the cerebellum is seen in about 30% of patients. Eye involvement concurrently occurs in about 15% of patients. Cerebrospinal fluid involvement in about 20% of patients. Spinal cord involvement is rare, seen in about 1% of patients. Imaging features in most cases is pretty straightforward. As you can see here, this is a very classic representation of primary CNS lymphoma. It's a deep location, irregular borders, homogeneously enhancing to gadolinium with T2 signal changes around the enhancing component, which represents invasive disease. This is not just edema. We do think of primary CNS lymphoma as a whole brain disease. And then on diffusion weighted images, or ADC, we could see restricted diffusion. And this is a classic appearance of a primary CNS lymphoma. Diagnosis is recommended now by brain biopsy. We do recommend to defer corticosteroids until a biopsy is obtained. Surgical resection is not recommended unless there's a concern for brain herniation or hemorrhage from a surgical standpoint itself. But unlike other primary brain tumors, surgical resection is not recommended, as these patients and these tumors are responsive to chemotherapy. But we do recommend an early diagnosis and taking patients early to biopsy to institute treatment quickly enough, because this has been shown in the context of clinical trials, not only to lead to neurologic recovery, but also to improve overall survival. And so with that, other diagnostic procedures such as standard CSF cytopathologic analysis or vitreous analysis from the eye have low yield and may delay diagnosis and treatment. And so again, if the tumor can be biopsied, we recommend a brain biopsy. The International Primary CNS Lymphoma Collaborative Group, or IPCG, recommends a baseline evaluation once the diagnosis is made. And this includes evaluation of clinical factors, prognostic factors such as age and performance status, laboratory evaluation, and then importantly, extent of disease evaluation, which includes imaging of the brain and spine, CSF studies, slit lamp examination, and then ruling out systemic disease by PET scan of the body. And if a CT scan is obtained in the absence of PET, a testicular ultrasound in older men is recommended to rule out primary testicular lymphoma, which quite has a predilection for CNS involvement. We nowadays recommend to skip a bone marrow biopsy if the patient's not on a clinical trial, unless you have a strong suspicion for bone marrow involvement. And IPCG also recommends evaluation of neurocognitive function at baseline if possible. IPCG also has additional guidelines now from an imaging standpoint with assessment of non-enhancing tumor, and then also guidelines to determine the difference between tumor relapse and treatment effect. And this is particularly now that we are using immunotherapies and cellular therapies where we can see tumor flare and pseudoprogression. And then it also recommends the utilization of DCE or DSC MRI to evaluate vascular permeability. And then there are also now papers coming out about circulating tumor DNA in CSF and its utility in diagnosis, as well as measuring minimal residual disease in the nervous system, although this is not currently used as standard. These are guidelines that were published by Lauren Avery and colleagues in 2005 for response criteria. And here you could see that the IPCG utilizes imaging with contrast enhancement, corticosteroid dosing, eye examination, as well as CSF cytology. We're now in 2025, so 15 years later, 20 years later, we think that these guidelines need to be updated based on all of the data that has been accumulated and the advances that have been made. And we expect to publish these guidelines in this year. At this time, there are two prognostic models that are used for evaluation of patients, and both utilize age and performance status, as these are the only two factors that have been found to be independently associated with diagnosis. According to the MSKCC prognostic model, the age cutoff is 50, and based on the ILSG, which is the International Extranodal Lymphoma Study Group, the age cutoff is 60 years of age. Both use a KPS cutoff of 70. The ILSG also utilizes serum LDH, CSF protein, and deep brain involvement. And it's important to note that as of right now, we have not determined any molecular prognostic or predictive markers that are associated with prognosis or predictive of treatment response. However, some candidate biomarkers that are being investigated and have been shown to be of utility are interleukin 10 in CSF, and some studies have shown that CSF interleukin 10 at the end of treatment can correlate with progression-free survival. And then there are some studies that have been showing the relevance of CSF ctDNA, which correlates with radiographic features as well as association with treatment response. These studies need to be validated further. And then there was this one paper which has shown that pretreatment plasma ctDNA correlates with a poor progression-free survival and overall survival. This was published in 2023. And again, we need validation studies to see how these pan out in prospective trials. Historically, the prognosis of primary CNS lymphoma patients has been poor, with a 1-year overall survival of 50%. However, with recent advances in optimization of treatments, the median overall survival is increasing and has gone from 12 months in the 1970s and 80s to 26 months in 2010s. We have seen improvement in overall survival, and the 5-year overall survival, specifically in younger patients younger than 65 years of age. However, there has been no change in survival in elderly over time. These statistics are not from prospective clinical trials, but are from population studies, and so those need to be taken into consideration as well. The treatment of primary CNS lymphoma has evolved since the 1980s from whole brain radiation to the 1990s, seeing the introduction of high-dose methotrexate. In the 2000s, seeing the addition of high-dose chemotherapy and stem cell rescue. And in 2025, we are exploring the role of targeted therapy and immunotherapy in upfront regimens and also for consolidative treatments, replacing whole brain radiation, how quickly it will be utilized in prime time, and for standard of care patients and also for patients all over the world, time will tell. So I'll start with a case as I go through treatment for primary CNS lymphoma. And this is one of my patients, was a 55-year-old woman who had a classic appearance of primary CNS lymphoma, had a brain biopsy, had no eye involvement, had eye involvement, but no CSF involvement at baseline. And so we questioned what would be the first-line treatment for this 55-year-old patient with this brain and eye disease. So the treatment of newly diagnosed primary CNS lymphoma is now established and involves two phases. One is induction and one is consolidation. The goal of induction therapy is to achieve a complete response, especially if consolidation cannot be offered. And so high-dose chemotherapy until now remains the standard of care. Should we add other treatments to high-dose methotrexate? Well, there have been two sequential studies from the same group from ILSG that showed that addition of chemotherapy or immunotherapy such as cytarabine, rituximab, and Thai-Tepa sequentially have shown that response rates are better with the addition of chemotherapy. Several different regimens are used all over the world, in different parts of the world. In the United States, we typically use either the MTRA or the RMPVA regimen, which are methotrexate, temozolomide, rituximab, followed by cytarabine, or rituximab, methotrexate, procarbazine, and vincristine, followed by cytarabine. And then in Europe, matrix or methotrexate, cytarabine, Thai-Tepa, and rituximab, and the RMBPVA regimen, which is rituximab, methotrexate, carmustine, tonopazide, prednisone, followed by Ara-C, are used. So as such, we don't have a standardized regimen. What we do recommend is high-dose methotrexate should be used, and alkylating agents and cytarabine should be added. And then I'll talk briefly about the role of rituximab. Is any one regimen better than the other? These are some of the prospective trials, except for the last one here that you could see, that show that the response rates to even methotrexate alone are approximately similar to about 50% in the context of prospective trials. And the ORR are also similar. The progression-free survival in these cases really depends on what specific consolidative regimen was used and if patients did receive consolidation or not. And as I was talking about the role of rituximab, this remains to be seen. In the ILSG study, there was a significant role in terms of survival as well as response rates with the addition of rituximab. However, that was a phase 2 study and it was not powered to answer that question. So the HOVON and the ALLG group did a phase 3 study of the addition of rituximab to their baseline regimen. And here they did not see any difference in the event-free survival in this case. However, what was noted, in fact, was a difference in event-free survival in patients that were younger than 60 years of age. And so there was no difference noted in the elderly. Based on these results, the Dutch group and in the Netherlands, rituximab is not used in the upfront regimens. In most of us, rest of the world at different meetings have agreed to continue utilizing rituximab in our regimens based on other studies. So coming to our patient, a 55-year-old woman, she received our MTR regimen followed by cytarabine. And you could see based on her imaging that she had a complete response in the brain and on eye exam had a complete response in the eyes. And so she's 55, so I wondered what could be the consolidative treatment and does she even need that? And so we know that based on this patient that you saw, as well as based on results of several studies, that we can get a complete response radiographically and in the CSF cytology utilizing high-dose methotrexate-based chemotherapy. But there is a high risk of recurrence in patients that do not receive consolidation. And so consolidation is really to prevent disease recurrence. And what we utilize is whole brain radiation, high-dose chemotherapy with transplant, and chemotherapy alone. What we do know is that the combination of chemotherapy and radiation can cause neurotoxicity, and these are studies that were conducted with full dose or standard dose whole brain radiation, where a significant amount of neurotoxicity with brain atrophy and large ventricles and significant leukoencephalopathy was seen radiographically, and patients manifest with impaired attention, executive function, verbal memory, and psychomotor speed. Importantly, this is irreversible, progressive, and fatal, and its incidence increases with prolonged survival. And so the now NRG and prior RTOG conducted a randomized study of reduced dose or low dose whole brain radiation. This is at 23.4 gray. And this was a randomized phase 2 trial where with a 1:1 randomization where low dose radiation was delivered to half of the patients. And here there was a clear difference in progression-free survival in patients that received low dose whole brain radiation compared to chemotherapy alone. The final results of overall survival were continuing and pending at the time of these results that were discussed in 2020, and neuropsych testing was also ongoing. We expect the publication to come out sometime this year and final results to be declared. What about stem cell transplant or autologous stem cell transplant, which is Thiatepa-based? These are two randomized studies that compared standard dose whole brain radiation to transplant, and both showed very good responses with and very good results with respect to progression-free survival and overall survival. In one of the studies, Thiatepa and BCNU was utilized as conditioning, and then the other study utilized Thiatepa, busulfan, and cyclophosphamide. At 7 to 8 years on the ILSG study, there was no difference in survival, progression-free or overall survival on the radiation versus the transplant arm. However, on the PRECISE study, that was the French study, there was a significant improvement on the transplant arm in event-free survival at 67%. However, the overall survival was not different. Again, it was quite clear that cognitive decline did occur in all patients with whole brain radiation the longer they survived. So we, through the Alliance, conducted a phase 2 trial of a transplant versus chemotherapy alone. And here we saw that the median progression-free survival was longer on the transplant arm. However, what we did note was that there were higher number of progressors with the same induction therapy on the non-myeloablative or the chemotherapy alone arm. So we looked at PFS from start of consolidations, you could see in these figures, and this was not statistically significant, although there was a trend to improve survival on the transplant arm. So the ILSG conducted a phase 3 study of transplant versus chemotherapy. And here the results were quite clear in favor of the transplant arm. You could see progression-free survival as well as overall survival significantly improved on the transplant arm versus chemotherapy alone. So on basis of these studies, we now recommend a Thiatepa-based transplant to all younger patients that can tolerate it and are candidates for such therapy. So as you could see, what can we choose? We could go with transplant where the risk of relapse is clearly lower, but there is a high risk of infectious and GI complications and treatment-associated mortality. Also, importantly, it requires an inpatient stay, whereas we could also offer low-dose radiation where they may be a slightly higher risk of relapse, but it's better tolerated, it's outpatient, and transplant can be considered at relapse. With our patient, she received a Thiatepa-based transplant. The challenges that we face with the current upfront regimens are that transplant and radiation are available only for the younger select population, transplant specifically younger patients without comorbidities, and radiation for those with preserved neurocognitive function. And so approximately half of our patients do not qualify for consolidation. And so these therapies have not contributed to improved outcomes in the elderly, which represent the majority of patients. And then an important group, which is the refractory disease patients, we have about 15 to 25% of patients that are refractory to initial high-dose methotrexate-based chemotherapy. So we do need to optimize upfront induction regimens. So we'll continue along with our patient. So 3 months after transplant, patient had a gait imbalance and had an MRI. We could see quite profound involvement of the brain here in the deep areas of the brain, corpus callosum, and diffuse patchy enhancement. So what will we treat her with? And this is the challenging part. There is no standard of care treatment option for relapsed and refractory primary CNS lymphoma, and so this remains a very open question. The prognosis of relapsed and refractory patients is quite poor. The median overall survival is about 6 to 7 months. The 3-year overall survival is 25%. And in patients that receive transplant, it can be a slightly higher. However, now we are including transplant in our upfront regimens, and so this doesn't really remain an option. This is just a figure or a slide that shows all of the prospective trials with chemotherapy that have been conducted and that show you that the response rates are reasonable with re-challenging chemotherapy. However, the progression-free survival and the overall survival remains quite dismal. And the only standouts here, as I mentioned, are the transplant, which no longer remains an option in our transplanted patients. So this allows me to segue into the biology of primary CNS lymphoma and the greater part of my work in this disease. So in the past, we have considered primary CNS lymphoma to be quite indistinguishable from a systemic diffuse large B-cell lymphoma based on histopathology. And based on gene expression profiling, it fits into the ABC or the activated B-cell non-GCB subtype of diffuse large B-cell lymphomas. However, based on comprehensive genomic analysis, we now recognize that primary CNS lymphomas, as you could see in this disease, has several copy number alterations, mutations, and chromosomal rearrangements that are quite distinct from diffuse large B-cell lymphoma. And this forms the basis of targeted therapy, which have not been shown to be, some of them, to be quite effective in systemic diffuse large B-cell lymphoma because of different genomics. Here you could see that the B-cell receptor signaling pathway is quite active in primary CNS lymphoma, and primary CNS lymphoma exhibit near uniform increased alterations and mutations of MYD88 through toll-like receptor signaling pathway and CD79B through B-cell receptor signaling pathway. Now, BTK here, or Bruton's tyrosine kinase, links toll-like receptor and BCR to NF-kappa B. So you could see there are several signaling pathway nodes that could be targeted. So here you could target BTK, PI3 kinase, SEEK, IRAK, and then further downstream, IMiDs could be targeted. And these have been explored in the context of clinical trials, which I'll show you just in a minute. So in the context of PI3 kinase, AKT, and mTOR pathway, we and others have shown that this pathway is active and in our PDXs, and there are ongoing studies of the combination of a PI3 kinase alpha and delta inhibitor, copanlisib, with a BTK inhibitor in relapsed refractory primary CNS lymphoma, and a study that we have of paxelisib, which is a pan-PI3 kinase, an mTOR oral inhibitor that penetrates the brain in relapsed refractory primary CNS lymphoma as well. Moving to the most studied drug and pathway that is targeted in primary and secondary CNS lymphoma, which is BTK. And I'll start with single agent utilization of ibrutinib, which was the first of its kind studied in all of lymphomas and heme malignancies, as well as in primary and secondary CNS lymphoma. So in the phase 1 and 2 studies, response rates were 77 and 52% respectively. And in both studies, median progression-free survival with single agent use was quite dismal, under 6 months. However, response rates were quite high. And these folks did show that ibrutinib concentrations were adequate in CSF and that the drug was well tolerated. And so combinations with chemotherapy were also studied. And here you could see that in a phase 1 study with dose-adjusted TED-ER, response rates were 72%. And in a study with rituximab and methotrexate, response rates were 89%. And in both studies, the median progression-free survival were longer than 12 months. These were, of course, phase 1 studies. What we did note in the context of specifically one study was that there were unique toxicities noted with ibrutinib, specifically aspergillosis noted in the brain and lung. And in the phase 1 study with a dose-adjusted TED-ER regimen, there were 28% deaths that were related to the addition of ibrutinib to this combination chemotherapy. And this was thought to be related to antagonism by ibrutinib of wild-type BTK in myeloid cells that mediate the innate immune control of Aspergillus infection. What's important to note, in all other studies with BTK inhibitors, the invasive aspergillosis has been noted, but less than 5%. So what the group at NCI did was that they added isavuconazole, which is an antifungal agent, to the dose-adjusted TED-ER regimen, and these results were shown by Mark Roshevsky at ASH just a few weeks ago. And here you could see that with this, they did not note any increased number of deaths. And importantly, they noted a 2-year progression-free survival of 28% with this combination and also utilizing concurrent antifungal therapy. So moving to next generation BTK inhibitor that has been studied in Japan and is currently being studied in the United States, tirabrutinib. In this phase 1/2 study, the response rate was 64% in all patients, and in their recommended fasted group, it was 52.9%. And on basis of this study, this drug was approved for a relapse and refractory primary CNS lymphoma in Japan. Now, we noted that the median progression-free survival with single-agent ibrutinib and tirabrutinib were low, under 6 months. However, there were a group of patients that were noted to have longer responses. And so long-term responses were noted, and both these studies, the long-term data, the top from Christian Gromis and colleagues, where they looked at 46 patients treated with primary and secondary CNS lymphoma, and the 1-year progression-free survival with this was 24%. What they noted specifically was that patients that had a longer response to ibrutinib had mutations of the TBL1 XR mutation, and those that had a shorter response to ibrutinib did not have this specific mutation. With tirabrutinib in 44 patients, the 1-year progression-free survival, it was about 36%, a little higher than noted with ibrutinib. So clearly there's a group of patients that do have long-term responses with a single agent BTK inhibition, and it remains to be seen if we can tell genomically or molecularly which are the patients that would have a longer term response. There is currently an ongoing study of tirabrutinib in the United States that has completed accrual, and this drug has also been added to the upfront regimens. And there's a dose escalation study of next generation BTK inhibitor acalabrutinib in relapse refractory CNS lymphoma that is currently ongoing as well. What other BTK inhibitor have been investigated in primary CNS lymphoma? Where these are results of early results of zanubrutinib in relapse refractory primary CNS lymphoma, the first cohort that was presented at EHA a few months ago by Chris Fox. And here you could see that many of these patients had poor performance status and were heavily pretreated. And the objective response rate was 50%. We do not yet have the durability response, and they are looking to combine zanubrutinib with other agents in their cohort 2. Next, moving to targeting IRAK4. Well, I showed you earlier in the figure that there's clear dual inhibition of TLR, or the toll-like receptor, and BCR signaling pathways. And there have been preclinical data that shows that combining BTK inhibition and IRAK4 inhibition increases cell sensitivity and apoptosis in BTK-resistant cell models. It has also been noted that a specific IRAK4 inhibitor, emavusertib, is blood-brain barrier penetrant, and there is activity in CNS PDXs, as well as relapse refractory non-Hodgkin's lymphoma. And so there is an ongoing study of emavusertib, which is an IRAK4 inhibitor, in combination with ibrutinib in relapse refractory primary CNS lymphoma after progression on single agent BTK inhibitor. Moving to IMiDs, which have been also studied in relapse refractory primary CNS lymphoma in the context of phase 1 and 2 studies. Lenalidomide and pomalidomide have been studied by themselves or in combination with rituximab, and the response rates are about 50 to 60%, with a median progression-free survival of about 6 months. Moving to the role of immune checkpoint inhibition, just some of my work, there have been some preclinical data that showed that there's increased expression of PD-L1 and PD-L2 in primary CNS lymphoma, as well as expression of immune checkpoints in the primary CNS lymphoma tumor microenvironment, which shows that there is a feature of immune evasion signaling in primary CNS lymphoma and a role for checkpoint inhibition. Although we noted that there was a good response to single-agent checkpoint inhibition in our initial studies, a phase 2 study of nivolumab as well as pembrolizumab did not show impressive results as single agents. What we did note was that single-agent checkpoint inhibition does take about 2 to 3 months to achieve a response, which is not ideal by itself in the relapse refractory population where the patients progress quite rapidly. However, unique structural combinations exist in primary CNS lymphoma, and so we and others have extrapolated that from combining from our PDX studies, as well as from other groups. And there are now several ongoing studies of combining BTK inhibitors with checkpoint inhibitors based on the genomics of primary CNS lymphoma, and also based on the knowing that BTK inhibitors do work a bit quickly and can provide synergy and increased activity of checkpoint inhibition. And so this was a study of orelabrutinib with sintilimab, which was shown at EHA in 2022, that the responses with the combination were impressive at 60% and similar, but at 1 year progression-free survival was quite impressive at 67%. Additional results are awaited. And then other combinations that have been studied are combining BTK inhibitors with IMiDs and rituximab, and this was a phase 1/2 study of ibrutinib, lenalidomide, and rituximab, where the 1 year progression-free survival, but the combination was 37%. And finally, this talk would not be complete without discussing the role of immune cellular therapies and CAR T-cell therapy. And this was the first study of tisagenlecleucel that was published in primary CNS lymphoma, where in 12 patients, a response rate of 58% was noted. And in a pilot study of axi-cel that we conducted, and we showed these results at ASCO last year, in 18 patients, we did not notice any grade 4 or 5 ICANS. Any grade ICANS were noted in 44% of patients, and our patients were quite heavily pretreated, and we had 13 patients with primary CNS lymphoma and 5 patients with secondary CNS lymphoma. These are our efficacy results, and our duration of response in this set of patients was 13 months. The response rate was CR rate was 67% and PR rate was 28%. The median time to best response, though, was 3 months. Progression-free survival was 14 months, and overall survival was 26 months in this very difficult to treat population. So concluding with the story of our patient, she received, after transplant relapse, ibrutinib at 840 milligrams on a clinical trial and had a complete response in 4 months. However, progressed and went on to progress further within 6 months. Some of the challenges that we face with immunotherapies are that the responses and targeted therapies or the responses are short. We've delayed responses with immunotherapies, which leads to neurologic deterioration. Corticosteroids can cause infections and can interfere with the efficacy of checkpoint inhibitors. There's a concern for neurotoxicity with cellular therapies. There's the issue of blood-brain barrier. We clearly need combinations, and we also need to include these therapies in upfront regimens. In conclusion, primary CNS lymphoma is a distinct disease. We absolutely need tissue. Prognostic factors include age and performance status. We are exploring molecular features. Early diagnosis and institution of treatment is important. High-dose methotrexate-based chemotherapy followed by thiotype-based transplant is recommended for eligible patients. Ibrutinib and lenalidomide show early data for response and are included in the NCCN guidelines for relapse refractory disease. And CD19-directed CAR T-cell therapy does show exceptional promise in the right population. With that, I'd like to thank all of my group and collaborators, funding sources, and importantly, patients and their families. And with that, I'd like to take questions and continue discussion.
Thank you, ma'am, for an excellent talk. Wonderful talk. Fabulous. Thanks a lot, ma'am.
Thank
Now,
you.
I request all our Indian colleagues so that we can start our question answer session to please put the raise hand signs. Yes, we have Dr. Rajan over here first. Dr. Rajan, go ahead with your question.
Dr. Lakshmi, thanks for the talk. I stand enlightened. My question is in two parts. First, what, according to you, is the indication for radiation upfront in primary CNS lymphoma? And second, like we talk a lot about methotrexate toxicity being accentuated post radiation. Does that hold any weight? Thank you.
Thanks. I think I'll start with the second question first in terms of methotrexate and radiation-related toxicity. There's increasing and significant data now that the combination with prolonged survival does lead to significant neurotoxicity, which is at this time irreversible. I think the risk is quite high, as noted in studies in patients over 60 years of age. I think what remains to be seen is how low-dose radiation patients fare. Denise Correa from Memorial Sloan Kettering has published data on, long-term data from the patients that received low-dose radiation, where the results were not as poor as what was noted with the standard radiation. That being said, what they actually found, the Memorial group, was after 5 years of therapy, both transplant and radiation patients tend to have worsening neurocognitive function. Now, that was noted by the Memorial Sloan Kettering group. However, when you look at the ILSG and the PRECISE study, both looked at transplant versus radiation. In both those studies, they looked at data over 8 or 9 years and 10 years, and they haven't noted worsening with transplant compared to radiation. So I think the challenge is, what are we seeing with low-dose radiation? And this brings me into your next question, is what are the thoughts on low-dose radiation? Now, transplant is not feasible in all patients, and it's not feasible in all locations. So there are several times when I get consults from different parts of the world where, if the location does not have a transplant eligible, a transplant center, this doesn't become an alternative. And then there's post-transplant care. Can you reliably see your patients come back for follow-up and not, fall into that transplant-associated mortality window within 6 months because of transplant complications? So I think in that regard, either chemotherapy alone or low-dose radiation can be considered as options. And I think as we particularly go through, further trials with investigating, agents like ibrutinib, lenalidomide, which I see as one of the chats, is there a role for maintenance? And also bringing in, considering CD19-directed CAR T-cell therapy for consolidation. I think these are approaches that we will see in the future to see if these are really helpful. Now, speaking of just answering Dr. Chirag Shah's question, their role for ibrutinib and lenalidomide maintenance, I personally don't offer these to my patients outside of clinical trials. I do offer it in the context of clinical trials, or we have a clinical trial with combining checkpoint inhibitor with chemotherapy and then maintenance checkpoint inhibition. And then we have a trial of a BTK inhibitor, combining it with chemotherapy and then BTK maintenance for those patients that could not be undergoing transplant.
Thank you, ma'am.
Thank you so much.
Dr. Narendra Chaudhary, your question, please.
Yeah, thank you so much. My question is related to pediatric experience. Usually, primary CNS lymphoma is treated on the line of LMB 96 protocols or BFM protocols. So, what do you feel how different is management of primary CNS lymphoma in children from adult, whether we need multi-agent chemotherapy, and second doubt is whether we need high dose therapy with the stem cell rescue in like at the first remission only.
So, unfortunately, this is a question that I don't really have an answer to because the number of patients that are seen with pediatric primary CNS lymphoma are very minimal to conduct clinical trials to have objective data on. So I think that this would be on a case-by-case basis. And I would follow the regimens that are generally used as such. I don't have, I have anecdotal experience, but this is again, not patients that I treat personally. And so most of the patients that I've seen are in the relapse refractory setting. When they're 16 or older, I practically treat them as adults. However, I think there's a paper that was published a couple of years ago that showed the genomics of the pediatric primary CNS lymphoma are very different from the genomics of adult primary CNS lymphoma, in that there's no increased incidence of MYD88 mutations. So it's very hard to know biologically how the disease is and whether, there is indeed a need for high-dose chemotherapy and transplant in those cases.
Yeah, overall, with these pediatric protocols, the outcome is better than adults in
Correct. Yeah.
pediatric.
Even with chemotherapy alone.
Yeah.
Right.
Yeah.
Yeah.
Okay. Thank you so much.
Thank you, Dr. Narendra Chaudhary. Dr. Roshni Pandey, ma'am, your question, please.
Hello. Thank you for that wonderful talk. My first question is, if biopsy is not feasible for some reason, elderly patient not willing, is there any reason to go on basis of radiology to treat patients? Or if biopsy is difficult?
So, so in my practice, I don't treat without a definitive diagnosis. And in patients that we have treated, I would use high-dose methotrexate alone. I do not combine the therapy. I think the major issue is if you have a young patient, would you then go with an auto transplant? Now, your question is specifically for the elderly. In that case, transplant is not feasible anyway. And so I think, you could have a discussion with the patients and consider single agent high-dose methotrexate in that case, and sort of go from there. I see this question in terms of eldest age limit for MTR.
Ma'am, we will
And
take the audience questions afterwards. So I'm just
Okay.
following the questions first. So let us
Right.
finish questions from the discussions and then we'll pop up with the audience ones. I'll read out to you, ma'am. So, ma'am, any other question? Roshni,
Yeah,
ma'am?
the second question is, in elderly patients, how do we optimize treatment? If the performance status is not good, we tend to lower the first dose of methotrexate. So how much dose of methotrexate should we push into the induction overall? What is the optimal cumulative dose?
So my flat dose, even with the MTR regimen, is 3.5 grams per meter square. And specifically for the elderly, I don't use the 8 grams per meter square dose, specifically because even when you dose reduce it based on the creatinine clearance, it still is not ideal. We're now exploring the role of cystatin C instead of creatinine clearance to see if that would be helpful or beneficial. And we're also utilizing increasingly glucarpidase on standby to cleave methotrexate. But as you know, it's quite expensive, so it may not be feasible to be using to give more doses of high-dose methotrexate. In this case, what is important to know is that if you look back at all of the prior studies, from the 80s, any dose of 1 gram per meter square is reasonable enough to achieve a CNS brain parenchyma response. However, it's not going to be ideal for ocular lymphoma, and it's also not going to be ideal for CSF involvement. So one thing that I've sometimes sort of recommended is if you're not able to, give higher doses and you do have CSF involvement, then in those cases you could give systemic 1 gram methotrexate in conjunction with intrathecal, because the 1 gram may be better tolerated. And then you could sort of see if other agents, like a lower dose cytarabine, is tolerated as well at the end of that therapy.
And how much should the total dose be in the induction? What is the target?
The target, the recommendations currently based on most of the trials that we conducted in the US, whether it's RMPV or MTR, are 8 doses of methotrexate. But this is the ideal situation. If your patient is developing progressive renal toxicity, then you have to pause and stop. You could stop at CR, but if you're not offering consolidation, then that's also becomes a problem because we're really going based on imaging. We can't use a PET scan as it's not ideal for the brain. And there's a lot of clearly minimal residual disease and microscopic disease that we can't really see on the brain MRI, hence forms the recurrence, as you could imagine.
And the last question is, what is the actual benefit of rituximab? I mean, we all tend to use it, but is there any benefit?
I think that, as I was mentioning, the ILSG study showed this was phase 2, not power to look at the rituximab question, but they still looked at it in their long-term data too, and found that the addition of rituximab was better in terms of survival. And when there have been studies that were conducted, retrospective studies by the Memorial Sloan Kettering group, they looked at their data since the 1980s in about 500 patients. And so they separated them into pre-rituximab and post-rituximab era, and they found that patients with rituximab on the rituximab era did better. Then again, the randomized study that was conducted by the Dutch and the New Zealand Australasian group showed no difference in event-free survival, except for in the younger patients. So I think it's possible that the younger patients tend to do better. It's unclear why. So for that reason, we recommend patients to get rituximab at least if they're younger. And if they're contraindications, then we don't do it. So during COVID, for instance, we would avoid rituximab because of the concern, but we've resumed utilizing this. We've discussed this at multiple IPCG meetings now that I lead, and we have in conjunction with ASH every year. And overall, the group feels strongly about utilizing rituximab if feasible, cost not being an issue, and no contraindications as such. The Dutch government, though, does not permit, its use. It's not covered by their insurance.
And how long does one follow up with MRI? 2 years, 5 years?
So the IPCG recommends every 2 to 3 months follow up for the first 2 years, moving to 6 months for the next 3 years, and then yearly for up to 10 years. And then after 10 years, this recommendation is that you don't need to follow up. So I think we do this on a case-by-case basis. If the patient undergoes an auto transplant, then in the first 2 years, I will follow every 3 months and then increase the interval after that. The patients that don't undergo a transplant mostly tend to recur pretty quickly. So those we keep on a closer watch.
And the ocular examination has to be done each time?
Well,
follow-up.
if you have a baseline which is negative, then you're not obligated to repeating that or the CSF.
Because patients can have an isolated ocular relapse also, right?
Right. So then you would go with the symptoms if they never had at baseline or at the end of therapy.
Thank you so much.
Thank you, ma'am. Dr. Shyam Agarwal, sir, your question, please.
Yeah. We made an excellent talk, Dr. Lakshmi. It was really very, very highly updated talk. My question is, you have said that it is most of the time ABC type of NHL, DLBCL. Do you find GCB also? And if GCB is there, do you escalate your treatment or de-escalate as per the ABC or GCB as we do in the our peripheral DLBCL?
So I personally think that when you look back at the Hans classification, these didn't really include primary CNS lymphomas in the classification.
Okay.
So I never really appreciated using those terms for this, but and now we look mostly through genomics, and even in DLBCL, the data that came from the SHIP lab and NCI now classify them based on genomics. So I think that language is probably going to change over time. But speaking on that too, from a DLBCL standpoint, we think of double hit and triple hit being also more aggressive. And it's actually quite clear now that in PCNSL, it doesn't really matter double hit and the triple hit status as it does in systemic diffuse large B-cell lymphoma.
Okay. And how frequently you see the pediatric PCN, like primary CNS lymphoma? Because I think,
Yeah, so I don't take care of the pediatric patients, but I do liaise with the pediatric group at Children's Hospital. So when they see a patient that has progressed, they generally involve me. And then the more other common one that I'm more used to seeing is the PTLD post transplant. Which now we're using, other therapies for, like Tab-cel and T cells. So I think that has expanded treatment for that much better.
Okay. And what do you do if patient have a residual disease post transplant? What is the further treatment you offer?
So in most cases, the residual disease that is seen, if it's like very minor, which is like sub-centimeter or non-measurable, I personally just follow it, but I follow it closely for the first 2 or 3 months to see if that's relapsed. I know there are some colleagues that add a BTK inhibitor at that point, but I personally feel like we don't really know what's going on. These people have had biopsies. There's also calcification. I would suggest also looking at, in terms of residual disease, checking with the neuroradiologist about whether there's T1 shortening to make sure it's truly disease enhancement versus not. And then also look at CSF studies if you are truly concerned.
Okay. So is there any term like pseudo progression also in primary CNS lymphomas?
So we're utilizing this increasingly because, again, it's radio responsive and it's chemo responsive. So in the past, we never used to see this inflammation, so to speak. I personally feel that I'm not sure when we're using checkpoint inhibition and cellular therapy, whether it's truly pseudo-progression or is it that the disease is growing so rapidly before the drugs kick in.
Yes, yes.
It's hard to know
Yeah.
the difference, but it's a term that we're planning to use or at least utilize in response criteria in the next IPCG for relapsed refractory, because we don't want to take patients off too quickly, especially if that is
Yeah.
truly the case.
Yeah.
What I can tell you is that even with BTK inhibitors, or when I've used, for instance, ALK inhibitors in the T-cell lymphomas, that are ALK positive, like the ALCLs, I have noted enhancement appear several years, like maybe months into therapy.
Okay.
And then we went back and biopsied these lesions, and it was gliosis. So
Okay.
I think there is a true inflammatory response that can occur.
Okay. Okay. Thank you. Thank you very much, Dr. Lakshmi. Thank you.
Thank you, Dr. Shyam Agarwal. Dr. Akanksha Garg, your question, please.
Thank you, ma'am, for the very lucid talk. So my question is that, for the autologous stem cell transplant, is there any cutoff for the age of the patients? And is there any difference in, using the conditioning as thiotepa versus etoposide? Because, these
Right.
elderly patients are not able to tolerate the thiotepa. So can we replace it with etoposide? And is there any difference in the outcomes with that change?
So age cutoff, in the trials, the age cutoff has been 72. The Germans are currently conducting an elderly transplant trial where they're reducing the number of induction doses of methotrexate. They're giving only 2 doses of methotrexate, cytarabine, and rituximab, and then they're taking them to slightly reduced BCNU and thiotepa-based transplant. And those efficacy results look reasonable, but 40% of those patients didn't really make it to the auto anyway. I think the age depends on your evaluation as a transplant oncologist. So I make the determination myself to see if they're feasible. I'm not in favor of taking patients over 74, certainly to an auto without data, because I think the biology of the elderly is slightly different, and I'm not sure that going through an auto transplant is going to make a difference for them. The younger patients, I think it definitely shows that there is a better response in terms of that consolidative approach. At the end of the day, it's, if you think your patient can tolerate the aggressive treatment or not is really the case, because it has been shown to be feasible in elderly patients, or it is being now shown to be feasible. So it depends on the transplant center itself. The second part about conditioning, it's quite clear, the initial studies with in PCNSL were with BEAM, and the results were quite bad with BEAM. And there are now 2 separate retrospective studies that have looked at, or population retrospective studies that have shown that looked at BEAM, TBC, and BT. And it's quite clear that BEAM really fares poorly. And this was shown even in the prospective data. And then when you look at TBC versus BT, the data with TBC, which is with busulfan and cyclophosphamide, is better than with BT, which is BCNU and thiotepa. But then the mortality risk is higher with TBC. So what we do in our center is that if the patient is 60 or younger and in very good physical state, we use TBC. If they're 60 and older, or the younger patients with other comorbidities, we go for the BCNU and thiotepa because that's better tolerated. I don't think that etoposide works as well. And so I would rather not use it in a transplant setting, would use it as a consolidative approach if you did want to use like chemotherapy as such with cytarabine, for instance.
Okay, ma'am. Thank you. And ma'am, one more question was regarding, there are a few papers on maintenance temozolomide for the elderly population. So, I mean, I wanted to know your comments regarding the same.
So the Japanese study of maintenance, I think temozolomide showed that there was no difference in survival. So we're not using it. I think the Italian group is conducting currently a trial of maintenance temozolomide versus lenalidomide. So it would be good to see those results. But as such, maintenance temozolomide in the randomized setting has not shown to be of benefit.
Thank you so much.
Thank you, Dr. Dr. Deep Gala, your question, please.
Thank you, ma'am, for such a wonderful lecture. My question, continuing with the discussion on rituximab previously, ma'am, should we add or omit rituximab for patients with HIV-related primary CNS lymphoma?
I think if the HIV is well controlled, it seems reasonable to utilize it, and especially if it's EBV positive lymphoma, then I would definitely use the rituximab in that case.
And ma'am, regarding consolidation, what is the preferred choice? Is it only cytarabine or is it along with etoposide and cytarabine?
You mean in the HIV population, or
No, for
in
primary
any
CNS lymphoma, in
population
any
if you
population.
cannot give an auto? I personally use cytarabine alone, but cytarabine etoposide is quite reasonable. I found that combination that we used in the CLGB and the Alliance study it's quite toxic, so it's really tolerated by younger patients. So and the younger patients, we go through an auto transplant. So now we're looking at elderly population. I don't like to give even cytarabine over 75 years of age, but sometimes I'll dose reduce it to 2 grams. But again, it needs to be high DAC at the end of the day. So it's sort of like if they can tolerate it, you could use and then follow. But I think etoposide combining it with cytarabine in older patients can be quite toxic. But if you didn't have a transplant facility and you wanted to use chemo, then I would, in a younger patient, then I would use cytarabine and etoposide for sure.
Ma'am, my last question is there any utility of mid-88 PCR doing mid-88 on CSF, ma'am? Is there any utility or does it predict response to BTK inhibitor like the TBL1 XR1 mutation does? Does mid-88 PCR on CSF help?
So we have not seen, I think there are now 5 published studies that are prospective with BTK inhibitors, and none of them have shown a correlation with MYD88 mutations and response. So clearly there's some other reasons why BTK inhibitors work in the CNS compared to with DLBCL, where it's very clear if it's within the cluster 5 or the MCD classification. As you could see in the Phoenix trial, the addition of a BTK inhibitor to R-CHOP did matter in those cases. It's not the same with primary CNS lymphoma and secondary CNS lymphoma too. So right now we're using MYD88 PCRs and those difficult to biopsy or those that have been treated multiple times with steroids. We don't have the diagnosis, but we have suspicion for PCNSL as a marker. And then we're following it along as well, but as a predictive for outcomes. But again, I haven't seen a clear indication of whether if MYD88 is still present in CSF at the end of therapy and had a CR otherwise, if it truly correlates with an early progression versus not. Now, ctDNA is a separate issue, which we're also looking into. But that's, looking at more DNA fractions, other mutations, and then MYD88 by PCR, again, is a different method of picking it up. So it's unclear what that represents.
Last question is there any time gap that we should wait from stopping the steroids to doing a biopsy? Because many patients are on steroids or are receiving
Yeah.
steroids for the disease.
That's
Or
a
any
very good
signs
question.
on MRI, ma'am, that we should
Yeah.
be looking?
I would definitely think that then in this case, you want to bring your neurosurgeon and the neuroradiologist together. So, some of these lesions are pretty large. And if the MRI continues to show that there is a disease there, and the surgeon can actually target into the enhancing component where there's restricted diffusion changes, I think that's reasonable to go for. The other thing is that if you have the capability from a surgical standpoint to have a pathologist in the frozen room that can confirm that, there was lesional tissue compared to not, then the surgeon can close and, doesn't need to operate further or get more samples as such if it's an issue. And the other part that we personally recommend within our institution is I suggest for the surgeons then to do an open biopsy rather than stereotactic. But again, in an elderly patient, it may not be feasible to do an open. And that, again, depends entirely on the neurosurgical unit.
Thank you, ma'am.
Thank you, Dr. Deepika. Dr. Gopinathan, your question.
Good evening, ma'am. Thanks for the lecture with a lot of new updates. So my question is regarding a young boy who is 30-year-old, post-kidney transplant. He has developed a primary CNS lymphoma. He's on tacrolimus as immunosuppression, but kidney is already showing some degree of graft rejection. So at this point of time, how would we proceed ahead treating this patient?
So with the PTLs, is this EBV positive?
Yes, ma'am. This is EBV positive.
So generally, there are few approaches in this case. So many times they have ring enhancing lesions. And if it's like a single lesion, we've even considered asking the surgeon to resect the lesion. But if it's because it behaves slightly differently in my experience compared to, the typical immunocompetent invasive primary CNS lymphoma. If there are multiple lesions or if it's a deep lesion that cannot be resected, then I typically use rituximab alone for 4 doses weekly. And the 4 to 8 doses are repeat an MRI or imaging to see if it has resolved completely. And then I'll just follow with the reducing the immunosuppression. And then I like the use of tacrolimus in general rather than mycophenolate, because there is some thought of PI3 kinase activity against PCNSL anyway. Again, it's immunocompetent, but hopefully it does help in some ways. And then the other agent that I also recommend is dexamethasone 2 milligrams instead of, prednisone for maintenance too. Again, working with the renal transplant docs, but oftentimes they have to increase the doses or they have to add CellCept or mycophenolate, in which case then, you just have to follow along. And then I've used high-dose methotrexate in patients with the kidney transplant, but you have to be, of course, very careful. So what we've done is I'll start with 1 or 1.5 grams per meter square, see if they tolerate it, aggressively hydrate, and then keep the glucarpidase on board to treat with the glucarpidase. Occasionally, I've been able to get clearance from the hospital to give the glucarpidase up front right after at the 24-hour mark to clear off the methotrexate, in which case the kidney damage can be prevented. And then the other option is high-dose cytarabine instead of using high-dose methotrexate. In the past, I would go to whole brain radiation, but that's not an approach that I would want to use. Are you able to get tab-cel or the CTLs directed against EBV?
EBV CTLs, it means since this patient is already on immunosuppression, will we be able to get?
Yeah,
uh,
they can. So
they
we've worked with actually the transplant teams, and it's, in fact, I found it pretty successful, and I've utilized it in the younger patients for sure, and also in our other adult patients.
we did think that option for this patient, but then since he is already on an immunosuppressive prophylaxis, but then whether we'll be able to succeed is what I had a small doubt in my mind. And based on your trial showing ibrutinib, lenalidomide, rituximab, so can we consider that as an option, because his performance status may not be also that poor to withstand chemotherapy? So would you recommend using that as an option then?
You could use that as an option. Personally, would go with tab-cel or the CTLs before the ibrutinib option, only because the data on that is quite minimal. In my experience, I haven't used those agents yet in the PTLD population.
Thank
One more
you.
practical problem I have, ma'am. Most of the times, this primary CNS lymphoma patients are on Riles tube. If at all, we need to use ibrutinib, which is an oral capsule.
Yeah.
So, how do you manage, like at your center, or how it is being managed? Practical suggestions.
Sorry, how do you manage what?
So the
The
patient is on
ibrutinib which is
Riles tube.
available.
Patient is on Riles tube.
Oh,
Primary CNS lymphoma. Can we
I
go
see.
through Riles tube, ibrutinib capsules?
I've heard of it being used in other countries. So it's something that you would have to discuss with the I think the pharmacist.
Sure.
Thank you.
Thank you, Dr. Gopinathan. Dr. Aditya Chandial, your question.
Thank you, ma'am, for the excellent talk as always. So I have like a couple of questions regarding first of all, uh, regarding the role of steroids. So if we see the regimens that we have for the treatment for primary CNS lymphoma, there seems to be a transatlantic divide, I would say. MTR and MPV in US versus metrics being more followed in EU. So, in your opinion, like in some of the regimens like MTR, we do not have steroids in the induction protocol. So, where do you place, the role of steroids in the initial treatment, apart from patients who have like features of raised ICT, and where we have to give steroids to get rid of the cerebral edema? The second question is the role of regarding the role of transplant. So, in the ILSG 43 trial, where metrics followed by transplant versus RDEVIC was given as consolidation. So, in your opinion, how important is the induction protocol as far as suitability for transplant is concerned?
So steroids, that's an easy question. I don't think that there's a role of steroids outside of, initially managing patients until the methotrexate kicks in. You've probably seen this in your practice. As soon as you give methotrexate, within 48 to 72 hours, the patients start feeling better. It's more, prominently seen in patients that were treated pretty quickly after the diagnosis or the development of symptoms. Of course, if the symptoms have been going on for more than 6 months, then probably the brain is already damaged, and no amount of chemotherapy or resolution is going to help. I don't think that steroids are required to be a part of this therapy at all, with high-dose methotrexate being used. And in fact, I think it's detrimental to use steroids beyond the necessary time period in neurologic patients, because they do cause proximal myopathy. These patients already are, bedridden when they start off, and then they get, hospital-acquired myopathy, ICU-related myopathy, on top of it, steroid myopathy. It's very hard for them to recover. So I don't think we try to taper off steroids very quickly after the methotrexate is initiated and patients start feeling better. Your question about the transplant, I forgot what you meant. That this was related to the ILSG 43
Yeah.
study, where
My question was like the significance of induction
of
regimen.
the induction.
Matrix versus the other. Yeah.
So the ILSG study showed that it doesn't matter whether you're in a PR or a CR. If you're taking patients to an auto, it doesn't matter at the end of the day. So in that case, the induction really doesn't matter then. I mean, as long as we're using high-dose methotrexate-based chemotherapy. And so I don't necessarily feel that Matrix is a better regimen. I believe that adding cytarabine in the upfront, in the beginning with methotrexate, delays methotrexate. Methotrexate is the only thing that works quickly other than radiation, within hours to days, and steroids, of course, in terms of shrinking the tumor. Everything else takes time. So if you're, there's no data on neurologic recovery in the ILSG studies. There's limited data on their toxicities based on the ILSG studies, and how many patients really completed their therapies, how many require dose reductions. It's not trivial in the standard of care patients. So I would say that it's not necessarily something that absolutely needs to be the case. And then importantly, it's not all of Europe uses Matrix. In fact, several locations in Germany don't use the Matrix protocol. They use the RMPV protocol. And then all of France uses RMBVP, which was the basis for the PRECISE study. And the Netherlands also uses RMBVP. So I would say that, it is definitely different regimens all over the world. I wish we all agreed like we do in systemic lymphoma, but that is not to be.
Ma'am, I have two more questions. So first one is regarding like the selection of patients for autologous stem cell transplant as consolidation. So do all CRs need transplant as consolidation? And is there any data on better imaging techniques, like in terms of molecular imaging, that can help us in better identification of patients among the CRs on MRI who are going to benefit from transplant?
So right now we don't have those data for better imaging or molecular techniques. So in that sense, that any patient that has a CR would still need to go for an auto if eligible for an auto, because even those that have a CR have a high recurrence risk.
And finally, ma'am, we recently had a young patient, 30 years old, with primary CNS ALK negative ALCL. So in patients who are TNHLs, what is your preferred treatment strategy?
So I use, methotrexate and Temodar without the rituximab, and follow it with cytarabine, and then with an auto transplant. Most of these patients do recur. The PCNS T-cell lymphomas are quite aggressive. Even the CD30 positive and the ALK positives, which, have a better biology in terms of like better response or prognosis in terms of systemic disease, they still tend to have worsening. So my choice is generally to give them the auto right away. If they've recurred and they've not received an auto in the past, I have tried using allogeneic transplant, which is what you would do for a T-cell lymphoma. Otherwise, again, there's no long-term data on this, and it's all anecdotal. And then I've used brentuximab in the CD30 positive patients for recurrence as well.
Thank you.
Thank you, Dr. Aditya. Dr. Bagal will take some few questions from the audience, and I'll come back to you. There is one question regarding the use of polatuzumab in patients who have got CD79B positive primary CNS lymphoma. Is there any data regarding it?
So there's anecdotal data, but it has not been studied in prospective studies. And definitely there is activity from what I've seen too, but I'm not sure if it's like a durable response or not.
Thank you. Another question is from Dr. V.A. Arun. Do you incorporate rituximab in all the patients with high-dose methotrexate protocols in primary CNS lymphoma in routine practice?
Yeah, I do. Rituximab, yeah.
Yeah. Another question he has is from Dr. V.A. Arun. How challenging is delivery of matrix protocol at full dose in your patients?
I do not use matrix in my patients. I have used it in the recurrent setting a long time ago when we didn't have trials. I personally don't think that it adds to anything, any more better responses than with MTR, which is what I use, or RMPV, which I used to use before.
Thank you, ma'am. Another question from Dr. Xijin Liang. Any trial of using incorporation of new generation BTK inhibitor like acalabrutinib or zanubrutinib upfront or in lab setting in case of primary CNS lymphoma?
I'm aware of ibrutinib and tirabrutinib in the upfront settings and trials. There could be something that I've missed if there may be newer trials. There's definitely trials in the relapse refractory setting with Xanu and Acala. I don't think there's an upfront trial with acalabrutinib as far as I know.
Thank you, ma'am. Another question she has is any role of intrathecal rituximab in relapse refractory primary CNS lymphoma?
There was a study that was conducted by James Rubenstein. I think that it's a bit hard to know how much of penetration of these molecules occurs through the CSF into the brain parenchyma for parenchymal disease. And rituximab by itself is a weak agent. Something that you would consider as palliative treatment, if you absolutely wanted to try something, but wouldn't use it in absence of others.
Thank you. And is complete remission required before transplant, or we can proceed without a complete remission before transplant?
So in the past, we would take only those in CRs. We're taking those that are in near CR to an auto, and the PRs we consider as well. And if you look at the ILSG trials, they took the PRs to an auto as well. So I think that's reasonable, as long as you think that the patient is chemosensitive.
Thank you, ma'am. And regarding the dose of methotrexate which you use in your primary CNS lymphoma, do you stick to 1 gram per meter square, as you said, or to maximum of 3 gram per meter square?
No, I use 3.5. I don't use 1 gram. I was saying that any dose over 1 gram is considered high dose for brain parenchyma, but I use the flat dose of 3.5. And then in patients that have ocular disease and are young, I use 8 grams per meter square for better ocular penetration.
Thank you, ma'am. And another question is from Dr. V.A. Arun. Regarding the two effective considered regimens which you told in 2025, that is reduced dose WBRT versus thiotype-based transplant. What is your best for according to you?
I don't think there's a trial of reduced dose radiation versus thiotepa-based transplant. there's a trial of reduced dose radiation versus no consolidation or consolidation with cytarabine alone. In my practice, I use transplant, as I was saying throughout the talk and in the course. But it's feasible to me, because we have the capability from a transplant center standpoint. And I think that is should be the favored approach for all young patients that are eligible, if possible.
Thank you, ma'am. Another question from Dr. Prasant Ganeshan. How do you manage isolated ophthalmological relapse after initial treatment?
So initial treatment would depend on what it would be. So I generally do use chemotherapy, systemic chemotherapy, either in conjunction or without intraocular chemo. We have trials now that include isolated ocular relapse as well, with the BTK inhibitors and checkpoint inhibitors. I'm not sure that CD19 directed CAR T cell therapy has good activity in the eye, from an immune standpoint, from the eye in terms of how the T cells survive within the vitreoretinal space. And then otherwise, I favor ocular radiation.
Thank you, ma'am. Another question from Dr. Chirag Shah regarding the role of ibrutinib and len maintenance, especially in those patients who have less than a CR.
I think I answered this before. There's no data on it, so you do that only in the context of a trial.
Exactly, ma'am. Thank you so much. Another question from Dr. Yimon Tent regarding autologous stem cell transplant versus CAR T cell therapy in relapse setting or as consolidation therapy. Which would you prefer, autologous transplant or CAR T cell therapy?
Well, I think there are two separate questions. So CAR T cell therapy is not approved in the United States for primary CNS lymphoma. We showed our data the data that I showed was in my study of CAR T cells in the relapse refractory setting, but that was in the context of a trial. We have other trials right now, or we're hoping to open trials that will allow consolidative CARs in patients that have completed induction chemotherapy. But that data remains to be seen, how the CARs will fare in the context of consolidation. If I had to pick between a transplant versus CAR for a relapse setting, if the patient hasn't undergone an auto transplant, is young, and is chemo responsive, then I would go with the auto transplant for sure. Because again, the data on CAR needs to be, build a little bit more and mature, right?
Absolutely, ma'am. Thank you so much, ma'am. Another question from Dr. Yimon Tent. What is the eldest age limit for methotrexate-based treatment? Maximum age limit?
I don't have an oldest age limit. My oldest that I've treated with methotrexate was 91. So I think the next question is about the dose for impaired liver.
Impaired.
I think this is, very much dependent on what are the resources that you have at the hospital to monitor these patients carefully and treat the toxicities if possible. So I would definitely not recommend, I have sometimes smaller centers that would even worry about giving methotrexate. And then we have them either come and travel to us, and if the patients are unwilling then or unable, it's challenging because it's not so much how good we are, a lot of times it's how good our nurses are.
Absolutely, ma'am. Another question from Dr. V.A. Arun. If the patient has been done PET scan initially, does he require testicular USG and bone marrow biopsy both along with PET scan?
We don't do bone marrow biopsies at all. We
Testicular USG for all?
do a we do a testicular ultrasound because we've missed some cases, but in practice and based on the data, if you have a PET scan, there's no reason to do an ultrasound.
Absolutely. Another question from Dr. Sinwin. I think it's a repeat question. For non-transplant patients, what should be the maintenance treatment for primary CNS lymphoma after induction and consolidation by either EA protocol or by WBRT? So would you, in a short words, would you go for maintenance after whole brain radiotherapy or EA after the MTR EA therapy or MTR whole brain radiotherapy protocol? Or just that would be the end of the treatment after the completion of
That would be the end of treatment. And part of the reason why I'm not a huge fan of maintenance is because you've seen in DLBCL, we've really not seen any maintenance to pan out and be helpful. So I'm not sure why we would see that in PCNSL as well. I think if they're going to recur, they'll recur. Now, of course, if Dr. Ferreri's trial shows us that there is an advantage of using lenalidomide, that would be good to see. But, you know, in the data from DLBs, based on the data from DLBCL in terms of even the CNS relapses in secondary CNS lymphoma, different biology, of course, but still, I'm not convinced that maintenance with what we have right now is going to be helpful.
Thank you, ma'am. And regarding the dose of rituximab, any experience regarding high dose rituximab at 500 mg per meter square versus 375?
Yeah, so MSKCC does routinely 500 milligrams per meter square. They use it every 2 weeks in their regimen. But with that dose, there was definitely noted leukopenias and neutropenias and sepsis. So GCSF or growth factors are definitely required. I use 375 milligrams per meter square weekly for 6 doses because a large molecule, hopefully the blood-brain barrier is a bit restored by the first 2 months, and then it's unclear how much will get in. We did a study that I led of higher dose rituximab 750 milligrams per meter square, and we looked at CSF PKs, and you know the CSF PKs don't look very good with rituximab compared to the blood PKs. So it's a bit unclear to me whether increasing the dose matters, but you know, rituximab, as you know, remains in the system for months after treatment. So there may be some other mechanism by which, you know, it triggers the immune cells in terms of how it sort of presents itself in PCNSL. But I also don't think it's unclear to me whether the maintenance helps or not. There is an obinutuzumab study now of maintenance obinutuzumab versus placebo, or you know, no treatment rather. That might help to know whether you know any maintenance therapy from a monoclonal antibody directed towards CD20 is helpful or not.
Exactly, ma'am. Thank you so much. Another question is that if patient has got vitreous lymphoma that do not respond to any kind of systemic treatment, how would you treat these patients as?
That has not received any treatment.
Responding to
I treat with,
not
sorry,
responding to vitreous lymphoma, not responding to systemic therapy.
Oh, I think we covered that. I would do either a trial with the BTK inhibitor or any other trial versus ocular radiation if no other alternatives.
Exactly. Thank you so much, ma'am. Another question we have is, well, can we combine Pembro plus ecalbrutinib in relapsed refractory primary CNS lymphoma? And if yes, what would be the dose of Pembro and what would be the dose of ecalbrutinib?
Well, I think we're currently doing an acalabrutinib study of dose escalation. We're going beyond to 100 milligrams per meter square, and we're looking at the PKs in CSF, but I don't think the ideal dose is known yet. of what is required for, there's no published studies of acalabrutinib yet. I just have my experience as such. There is a couple other people that are using acalabrutinib either by itself or in combination with, I think, durvalumab maybe, the other AstraZeneca PD-L1 drug. And then we have a study of ibrutinib with pembrolizumab, which we're using a flat dose of 200 milligrams per meter square every 3 weeks. But these are still ongoing. My colleague, Ugo Chukwuke, showed the data at one of the SNO meetings last year of the phase 1 of pembro and ibrutinib, where the MTD was 560 for ibrutinib, and the flat dose of pembrolizumab, 200 milligrams per meter square.
Thank you, ma'am. Another question we have is regarding a case of systemic DLBCL GCB subtype, stage 2, treated with 6 cycles of R-CHOP, now in CR1, and after that, 1 year later, patient had isolated CNS lesion diagnosed as CNS lymphoma of ABC subtype. Should we treat this as a primary CNS lymphoma now? And should we repeat the course of rituximab once again?
I mean, I would treat it as a secondary CNS lymphoma rather than a primary, unless we know something about the biology being different. And, routinely rituximab is used recurringly for recurrent disease or refractory disease in the systemic DLBCL protocol. So it's not, out of the ordinary to want to use that in the CNS as well in that situation.
Thank you, ma'am. And do you think that in near future, this is the question raised by Dr. Ali, that functional imaging like PETs can will replace the biopsy forever to diagnose a case of primary CNS lymphoma?
I don't think that imaging would ever replace, I mean, would any oncologist replace a biopsy with or tissue? I think maybe, hopefully we don't ever need biopsies of anything in the body, and blood alone is helpful to tell us. But I think we still need some pathologic evidence, whether it's spinal fluid or in the blood eventually. As Florian Scher and the Stanford colleagues showed that they did see plasma ctDNA, but again, that needs to be validated. I'm wondering if we should wrap up the
This
program.
last question, I think we've finished all the questions. And last question again from Dr. V.A. Arun. Any role of busulfan-based conditioning with allotransplant in relapsed refractory primary CNL patients in fit patients who has got early progression post autologous stem cell transplant?
So I think there's like maybe a publication from Europe. We have definitely, like I said, I've only done it in the context of secondary CNS lymphomas and T-cell lymphomas for recurrent disease. If there are no other approaches and the patient understands the risks, I think it's reasonable to do an RIC allo, after you have an initial response to induction. I don't say that there's data on it. It's hard to know.
Thank you, ma'am.
I think Dr. Pausab had some
Yes,
question.
one question from Dr. Pausab. Last question, we can take it. Yes, Dr. Pausab.
I mean, that got answered. I had one person with a isolated ocular relapse, which was within 3 to 6 months, and we are treating him with local intravitreal injections and started him on acalabrutinib. And I was curious to know whether we should add RT. But no, we discussed with our ophthalmology colleague, and what they feel is he's responding locally, and maybe for a systemic control, acalabrutinib should be feasible. There's no other option possible now for him. So
I think
thank you.
that the ocular responses, it's kind of interesting where if they just comes back isolated ocular only, they continue to respond to the injections many times. Like I even have like a T-cell lymphoma, which is the hardest to treat, but the ocular seems to respond to years and years of injections. And then, when they pause, it's fine for a few months and then it comes back again. And in fact, we're using even intraocular now melphalan because the methotrexate stopped working. But I think that I find it's a bit hard for patients to have to go through the injections on a persistent basis, but it's reasonable enough to do that. And I would wait to do the radiation or other treatments for when it progresses on that, because it's going to happen at some point. So you might as well, I don't know whether there's an added advantage.
All right. Yeah. So he progressed immediately after MTR, which was 8 gram per meter square. And
Yeah.
I was debating whether there is any value of systemic therapy for him. Then whatever benefit I had started him on acalabrutinib. But do you think these isolated ocular relapses would lead to, CNS relapse later on?
If they are not under control, possibly, right? So I think I think that's the issue. In most of the cases that I've had that didn't respond to the chemotherapy, whether it's local therapy versus systemic, it was they always recurred eventually in the brain within like the first 2 to 3 years. I personally am not so convinced that the systemic chemo gets in very well in the eye. But the French have published data on it and they have the largest series. So it's hard to ignore that data. So as a group, we decided between our ophthalmologists and us that we would use that as a baseline. I don't go for an auto transplant though in these patients in the first line setting unless they have a CNS relapse. But Tracy Batchelor favors going for an auto in the isolated ocular too.
Thank you.
Thank you, Dr. Lakshmi.
Thanks a lot. So with that, there are no more raising signs, and I've finished all the questions from the audience. Well, Dr. Lakshmi Naik, you were awesome, fantastic. What a wonderful lecture, and what a wonderful discussion we had. This 1 hour discussion, that was fabulous. Super.
Yeah.
I think you've cleared all our doubts regarding this primary CNS lymphoma. I think this will be better understanding for all of us now. And from tomorrow onwards, we'll be very, very confident regarding treating this primary CNS lymphoma. Thanks a lot once again, ma'am, for accepting our invitation as our guest speaker for the day. And hats off to you. And I also thank all our discussants as well as audience to participate in this webinar, and meet you tomorrow sharp 11:30 a.m. with another beautiful webinar. Once again, thanks a lot. Goodbye for now.
Thank you, and for staying so late in your Saturday evening.
Thanks to you, ma'am. Wonderful lecture, wonderful discussion. Thank you so much.
Thank you.
Hope to
Bye-bye.
see some of you at ICML or EHA.
Sure, 100%.
All right. Bye-bye.